Hi everyone, today we are going to talk about the bugbear in this whole field of neuroscience or neurorehabilitation, which is spasticity. My name is Nikhil. I am the head of physiotherapy and advanced neurorehab specialist at PRS Neurosciences. So let's start to understand what is spasticity. Spasticity is an increase in the muscle tone. So all of us, even if we sit, we stand, we walk, the muscles will be in a partially contracted state. This partially contracted state is called the muscle tone. So when they get an injury in the upper part of the nervous system, this tone can increase. This is called a hypertonia. So spasticity is one type of a hypertonia. If you move any part, there's a quick stretch that comes. So in spasticity, this stretch reflex get exaggerated. So two things, the muscle tone increases, and the second thing, it increases the stretch reflex. There's an increased response to a stretch reflex. So this is a characteristic of a spasticity. Next question, which all patients they get it? Anyone who gets a UMN injury, they can develop spasticity. So to understand a little bit about the upper motor neuron and the lower motor neuron, let's quickly understand what is UMN and what is LMN lesion. UMN lesion, the motor system, we say from this primary motor cortex, area number 4, the fibers, the processing and the final information comes to this primary motor cortex, and that is getting relayed across multiple neurons until it reaches to the final effector organ, which is the muscle. So the signals, the impulse pass across multiple neurons until it reaches to the anterior horn cells of the spinal cord. We call it as it is an upper motor neuron lesion. Anything starting from this anterior horn cells until it reaches to this muscle, it's called a lower motor neuron lesion. So spasticity can develop for anyone who has a upper motor neuron lesion. The question is, why upper motor neuron lesion patients they develop spasticity? To understand that, we need to understand couple of things. The first one, the organization of the pyramidal system. This include your primary motor cortex, your corona radiata, where it decussizes to internal capsule, it goes through the brain stem until it reaches to the medulla, where it crosses to the opposite side. It descends down as corticospinal tract through the spinal cord, and it reaches to the anterior horn cells at the respective level. So this is one tract which primarily controls the voluntary movement of it. But is it the only tract? No. There are other tracts which is closely associated in delivering these voluntary movements more effective, better, easier, smoother, whatever. These are the extrapyramidal tracts. This include your reticulospinal tract, rubrospinal tract, vestibulospinal tract, so on and so forth. So there are multiple extrapyramidal tracts that also controls your muscle tone. So when you do an action, the primary action is done by the cortical spinal tract, but for that the body need to be prepared. The muscle tone has to be adjusted in a way that you will be able to deliver this function in a smooth way. This is done by the extrapyramidal system, and this extrapyramidal system is also under the control of the pyramidal tract. The pyramidal tract effectively controls through its cerebellar circuits, through its reticular circuits. It has a good control over the pyramidal system. So when someone get an injury, these networks can get affected. So this extrapyramidal tracts can get fired in a haphazard way. When that happens, inherently all the neurons has a ability for excitation. So because of all of it, when the neuronal inhibition or the pyramidal inhibition stops, the muscles or the nerves get super excited, and that is called a spasticity. Because the inhibitory mechanisms, there are different neurotransmitters. The inhibitory neurotransmitters are not acting sufficiently at the synapses the muscles, the neurons get fired. This firing is this form of comes as a spasticity. So now when we tell about spasticity, is all tightnesses are spasticity? Absolutely not. So we can overall divide into 3-4 categories. I'm not talking, talking only motor related tightnesses. There are other reasons a muscle can be tight, which I am not going to include in this video. There are 3 things we should know. One is a spasticity, which we are discussing now. Second one is rigidity, which is also a different type of a muscle tightness, or a tightness of the of a muscle. So first we'll understand what these 3 things are. The first one, the easiest, is a muscle tightness or muscle contracture, whatever. It's a local problem. So the muscles are acting based on its sliding filament mechanism. You have actin fibers, myosin fibers, it slide one over the other. That's how the muscle contraction happens. Imagine this sliding is not smooth, or the efficiency, or it's not going in a very smooth way. That is a muscle tightness. It's a local problem. So when the problem is local, the treatment also need to be local. You can't do one treatment for all of it. If it's a local problem, treat the local problem separately. Next comes spasticity. Spasticity, the neurons are hyperactive, and especially this is velocity dependent. Means if you try to move it fast, the resistance will be more, but if you move it slow, the resistance will be lesser. This is a spasticity. So the problem is not here, not in the muscle. Problem is in the motor program or the hyperexcitation of the neurons. The third one is rigidity. This is velocity non-dependent. Means even if you move fast, you move slow, the tightness is going to be there. It can be a lead pipe type of rigidity, or it's a cogwheel type of rigidity. It catch and releases, it's a cogwheel. Throughout the range, if it gives a tightness, it's a lead pipe rigidity. Any of these things. And usually it affects both the muscle groups, both elbow flexors, extensors, ankle dorsiflexors, plantar flexors. Whereas spasticity, it will be more dominant on one group of muscles. Again, the reason we have discussed in the physiology. If you want to know more about the reason, you should read about how the vestibulospinal tract, reticulospinal tract, rubrospinal tract, how does it work, and what is the influence on the muscle tones. So overall spasticity, it is local, it is more to one group of muscles. Yeah, in extreme cases it can be both the sides, but generally it's on one side of the muscles. It's extremely velocity dependent, whereas rigidity, it is both the group of the muscles and its velocity non-dependent. The reason of rigidity is because of the basal ganglial circuits, the dopaminergic circuits in the brain slows down a little bit. That can cause the rigidity. The reason can be any. If you have not watched our Parkinson's video, how to deal with the rigidity, click this I button. You will understand how we can manage the rigidity. Now let's come back to the spasticity. The next question is what all conditions can cause spasticity? Answer is very, very simple. Anything which affects the upper motor neuron can cause spasticity. So you take a stroke, a big component, maybe 35%, 45% of spasticity is from stroke. Or can it happen in head injury? Of course it can happen in head injury. Can it happen in spinal cord injury? Yes. Multiple sclerosis? Yes. GBS? No, because it's a lower motor neuron injury. You will not get a spasticity in a lower motor neuron injury. So anything that affects the upper motor neuron, a lot of cases are there, like corticobasal degenerations or multisystem atrophies. All of these things can have a component of spasticity because the upper motor neurons are affected. Sometimes along with the spasticity, the local muscle tightness also can come. Because the hand is fixed in one position, it is not moved enough, so the sliding mechanism can get affected. So now it's a double trouble. You have spasticity, you have a local muscle tightness. And most of our patients, especially the chronic patients, when they come to us, we face these two challenges. So when someone comes to you with spasticity, just don't treat spasticity as an isolated thing. You need to treat spasticity in conjugation with the treatments for the muscle to be more smoother, the sliding to be more smoother. This includes the trigger points, this includes the myofascial releases. All of these things can help to address the local tightness, whereas spasticity, the plan is going to be different. Next question is, how do we assess spasticity? Worldwide, there are two scales which is predominantly in use. The first one is modified Ashworth scale. The starting from 0, if there is no spasticity, the score is 0 to 4, where it is extremely tight, you can't even move. If you want to know more, pause this video and read this. The next one is Tardieu scale. So if it is a diagnosed spasticity, modified Ashworth scale may be a better option, but sometimes we may not have a complete idea, is it really spasticity or is it spasticity with muscle tightness, how much is the component, we may have some difficulty in understanding. So that's where the Tardieu scale comes into picture. So Tardieu scale, we select the muscle group which we want to assess and we assess the muscle responses. When you are not sure about is it spasticity or is there any component of spasticity, how much is the spasticity versus muscle tightness, that's where the Tardieu scale comes into picture. Tardieu scale, we assess three things. One is how is the muscle reaction, starting from 1, 2, 3, 4, 5 you can say, and at different velocities. There are three velocities, V1, V2, V3. V1 is as slow as possible, V2 is at the level of gravity fall, V3 is as fast as possible. So pause this video, watch this to read about the Tardieu scale. So you do this, and at each velocity you measure the muscle responses. If muscle responses are wide apart, means with higher velocity, higher muscle responses are coming, that means the spasticity component is high. Or between, if everywhere is 2, 2, 2, like that it's there, it's more of tightness component than a spasticity component, or you can say spasticity component is generally less. So that's what the Tardieu scale tells. Along with that, it tells R1 and R2, these are the muscle ranges. So in Tardieu, three things, muscle responses we assess at three velocities, which is V1, V2, V3, and you measure R1, R2. These are the two ranges where the spasticity is manifested. So with this, we can understand the spasticity. You can quantify the spasticity in some objective way. It's a lot of subjective data involved in it, still in an objective way. But what my recommendation is, spasticity as such is not a problem. How much is the spasticity affecting the function is what we need to look specifically. So even if you do spasticity using modified Ashworth, Tardieu, none of these things will tell how much the spasticity is affecting the function. So it is paramount, it's very, very important to understand this aspect so that you can strategize your treatment in a functional way. At the end of the day, the patient need function. Patient, whether the muscle is tight, not tight, it may be a secondary requirement for the patient, but one of the primary thing will be function. So keep function in the middle, and tone evaluation is, you are doing a tone evaluation to identify how much the tone is impacting the function. That's how usually we at PRS Neurosciences, we assess and we see spasticity in a functional way, which help in treating our patients better.